Okay. 5, 4, 3, 2, 1. I'm going to start the webinar now. We'll just wait a little bit longer while people come in. Okay, I think we'll get started. So welcome everybody to today's workshop. Is this okay? Community attitudes on the use of health data in research, a cross-cultural exchange. My name's Felicity Flack and I'm the Senior Manager Strategy and Services at the Population Health Research Network, and I'll be your workshop facilitator for the day. This workshop is part of an ongoing collaboration between the Population Health Research Network in Australia and the Health Data Research Network Canada. Next. I'm speaking to you today from the University of Western Australia, whose campus is situated on Noongar land. Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, and beliefs. So now for some housekeeping. We'll have a question and answer session at the very end of the workshop, but please feel free to add your questions to the Q&A box at any time during the workshop, and we'll get to as many as we can towards the end. And this is an interactive workshop, and we will be using Mentimeter throughout the workshop, and I'll go through your Mentimeter instructions shortly. So throughout today's workshop, we will intersperse the presentations with questions and discussion prompts for the audience. We will ask you to contribute to the workshop by adding your responses in Mentimeter. Participation in Mentimeter is, of course, voluntary, and all the responses will be anonymous. If you do not want your responses to be included in these outputs, please do not use the Mentimeter. We are planning to summarise the workshop presentations and the question responses to feedback to workshop participants for a publication. So, Mentimeter. We're going to have a few sort of warm-up questions first. So if you can all either use the QR code on your screen or go to the Mentimeter site and type in the code and try and get onto Mentimeter for us. That would be great. I'll give you a minute or so to do that. I'm seeing lots of thumbs up, so that's very positive. All right. Oops. So first question. Can you tell us what your role is? Let's see if we can get the Mentimeter to work. Oh, it's looking good. Okay. A few more. Okay, looks like it's slowing down. And the next question, what land are you joining us from? I should just let you know that the Mentimeter code is in the chat. It should be the first entry in the chat. Okay. Did we have another question? Okay. Yes. Okay. Next question is, have you or your organisation engaged with community to understand community perspectives on sharing health data for secondary purposes? Okay, can we just flick back to the Mentimeter code and QR code? Because some people were saying the chat's disabled, so they can't see the code in the chat. There we go. So we'll just pop that up for a little moment while those of you couldn't see it can get to have a look at it. Okay, good. Looks like we're getting a few thumbs up there, so maybe 10 more seconds. Okay, I think we can move on now. It's looking good. Okay, great. Okay, now let's get on with the workshop proper. So the objectives for today are to compare engagement methods and experience between Australia and Canada, discuss the findings based on local context, and highlight emerging issues and lessons learned, as well as to facilitate cross-cultural exchange between Australia and Canada. PHRN and HDRN Canada are both collaborative network organisations dedicated to advancing multi-regional health research through the use of linked data. Our two presenters today are Dr. Julia Burt, the Public Engagement Lead for the Health Data Research Network Canada, and Professor Annette Brunak-Meyer, Head of the School of Health and Society from the University of Wollongong. And we're really delighted to have you both here, and I know the hard work that you've both put into preparing this workshop, and I'm really looking forward to it. So I'm going to hand over to Julia and Annette. Over to you.
Thank you, Felicity. I'll start us off. So I'm Julia Burt, and I'll just briefly say I'm coming to you from the province of Newfoundland and Labrador in Canada, or Uktuhumguk, and this is the ancestral homelands of the Beothuk, the Mi'kmaq, the Innu, and the Inuit. It's pretty late at night here, so I'm hoping that I will stay coherent through the next couple hours, but I'm really looking forward to this. So I'll get us started with some background. We like to show this slide and this graphic just to demonstrate how it is becoming increasingly understood that data, and particularly health data in this context, are very powerful. So here are just some of the many recent media and academic highlights about data. Many are actually about the COVID-19 pandemic, and the recognition that better data are really needed to be collected to solve public health problems. With the acknowledgement of the need for better data, there are also many considerations that arise. So considerations around privacy concerns, people accessing their own health data, and you could see some of those on the slide there as well. But overall, I think we can all agree that the importance of data is becoming increasingly understood, especially in the era of machine learning, big data, and artificial intelligence. So it's also important to acknowledge what we already know about how the public feel about health data use. So we know from existing work on this topic that members of the public see health data as an asset that should be used for public benefit, but their support is often conditional. So what we mean is that most people feel that certain conditions and risks must be addressed before they consider uses of health data to be acceptable. So there's some examples there on the slide. So if we're talking about privacy and security, for example, that could be something like people believe that data always needs to be de-identified. For commercial motives, that should be something like commercial organizations or the private sector should not be allowed to sell data, so that profit aspect. And for equity and fairness, a common kind of condition that we hear is really around data about systematically marginalized populations. So ensuring that data use doesn't result in discrimination or stigma against certain groups. There are some existing reports and studies on this topic on the slide. So there's an excellent systematic review that has a lot of the existing work on community attitudes there, as well as a consensus statement by the same group that I find quite helpful in this area. So before we get into details on the projects, both of our projects and what we heard, I think it's important to understand the terms social license and health data social license, because these are directly linked with the idea of community attitudes on the use of health data. So in terms of social license, the term actually started to be used more frequently and more initially in the mining industry. So you think about a mining company that goes into a community and starts to mine. The question is, do they have support of the community members? So in order to act responsibly, an additional moral duty exists. And this is beyond compliance with laws and regulations. So it is possible for an activity to be legally allowed, but outside of social license. Increasingly, the term is being used to describe which data-related activities have the support of members of the public and under what conditions. And in our context, we're talking about health data. So to say that a use or user of health data is within social license means that it is one of the uses or users of health data that at a minimum is publicly acceptable, but ideally has active public support. And again, there are some resources there on the slide that describe this concept of social license in more detail, but we'd be happy to share them with anyone who's interested in learning more. So I think we have another Mentimeter.
Yes. So first of all, we'd like you to turn your minds to what either you've done or you know that your organization has done to gauge community attitudes towards the use of data for research. Fantastic.
Thanks, everyone. So I will keep going for a little bit. Now that we've provided some background and additional context into the existing research on community attitudes, we'll now talk about the methods that each of us respectively took to engage with the public to learn about their perspectives on health data. And I saw some of the responses coming in: community juries, surveys, focus groups, and those are quite familiar. You'll hear a lot more about that later as well. So in terms of our work with Health Data Research Network Canada, what we really wanted to do was expand on the current research on community attitudes about health data by adding experienced public and patient advisors' views on two main things. One being essential requirements for health data social license. So, an essential requirement could be something like health data cannot be sold, or plain language needs to be used by entities who are collecting health data, or accountable governance bodies are in place. And the second thing we want to learn about were examples of health data uses and users that people felt were within, not within, and could be within social license. So, why did we choose this approach? Most of the previous research in this area asked people to provide their perspectives on health data uses and users, ones they felt were acceptable or unacceptable. So, what we decided to do was to see if there were select uses and users that everyone in the group that we engaged with agreed with. So, either uses and users that everyone opposed or everyone supported. So, essentially, we were trying to come to consensus on these essential requirements and examples of uses and users that people felt were within, not within, and could be within social license. And here's a brief kind of snapshot of the group that we engaged with. So, some select participant characteristics. A relatively diverse group, particularly in terms of ethnocultural backgrounds, but of course with limitations. It's obviously quite a small group, just 20 individuals, which is often a common limitation when you're doing this sort of research. You can also see that the individuals are primarily older and well educated, which again is quite common in this type of work. Half the individuals were French speaking and half the individuals were English speaking, so we conducted everything in both languages. Um, we did use the term participants for simplicity, but they were not participants in the traditional sense of the word. They really were patient and public advisors who were engaged with their core research team, and they were the drivers of the content that was created. They weren't study participants. I will note that there was an additional group of 13 patient and public advisors who we engaged with who were peer reviewers. So they reviewed the report that we developed, and they had similar characteristics. So ethnoculturally diverse, but primarily older and highly educated. So our high level approach, our methods really focused on inclusive public engagement, and we took a couple of different steps. So the first step, the participants provided individual written submissions where we asked them to identify essential requirements for health data social license, and also asked them to identify uses and users that they felt were within, not within, or could be within social license. For the essential requirements, we did give them a list of about 40 requirements that were based on previous literature, but we told them not to be constrained to this list. This was followed by 2 facilitated dialogue groups in English and in French to focus on both of these components. The results were then converted into a public report that was reviewed by experienced public and patient advisors. So it was reviewed by both the participants as well as that group of peer reviewers that I mentioned earlier. This was done in English and French and then shared with the Public Health Agency of Canada, who contracted this work and funded it, and then it was shared more widely. We then asked the participants and peer reviewers to evaluate the process using the Patient and Public Engagement Evaluation Tool, or the PPEET. This is a product of a Canadian collaboration of researchers in public and patient engagement out of McMaster University here in Canada. We'll be focused on the main findings today and not the results of the evaluation, but if you do have questions about the PPEET or the results, I'd be happy to answer them as well. So a little bit more about how we capture perspective. I'm going to briefly talk about 2 main ways that we capture perspective. So we took an inclusive design approach, and we took this approach so that we could identify diversity of views, and specifically we wanted to identify minority views that weren't likely captured in previous work in this area. And the second approach we took was using a 5-finger facilitation method. And this is a facilitation approach that helped participants come to consensus on examples of health data uses and users that they felt were within and not within social license. So now I'll give a bit more detail about both of these approaches and the principle of inclusive design. So for those who aren't familiar with inclusive design, we know that people who hold minority views are the ones who are least likely to be well served by the status quo. But they're also often the holders of knowledge that is essential to design processes, policies, procedures that work for everyone in the population, not just the majority. So the findings in the report that we created include views and requirements for health data social license that were supported by many people, but also ones that were supported by just 1 or 2 participants. And I think it's also important to acknowledge that the views of 1 or 2 people in our process could represent thousands or more people across Canada. So I like that image on the slide, on the right-hand side of the slide. It just shows the importance of using minority views when designing processes and policies that work for everyone, not just the majority. So in the context of inclusive design, it is understood that it's predominantly that those edge users, so the little dots on the outside near the red circle, that contribute the most relevant, innovative, insightful, and grounded perspectives to a diverse design team. So if you want innovation or even design improvement, the best people to have at the table are the ones that have difficulty with the current design. In the case of health data social license, better understanding minority views was a way to help us come to consensus on different examples of health data uses and users that everyone supported or opposed, hence being able to hopefully find a center of social license or uses and users that were supported or opposed by everyone. So just a little bit more about the facilitated dialogue approach. So as mentioned, the participants were involved in 2 facilitated dialogue sessions in English and French, where they had the opportunity to share their views, listen to each other, and be open to changing their minds after listening to others. But facilitators did make it clear that no one should feel pressured to change their mind on their views. So as I mentioned, the first session focused on essential requirements for health data social license, and the other focused on examples of uses and users that were within or not within social license. So we used this 5-finger facilitation method to help the participants come to consensus. So the good thing about this method is it's not kind of a yes/no binary approach. It's not voting per se. It's really a real-time expression of people's thoughts about a particular statement. So as an example, the facilitators would read out a statement like it is within social license for health data to be used by X. And then the participants would show on their fingers or show on their hands how much they supported that. So a fist would be complete opposition, 5 fingers would be full support, or anywhere in between. So this was important because participants could still express concerns about statements they agreed with. So it wasn't an all or none approach. The facilitators would then ask participants who were fully in agreement and those who had issues with the statement to share their views, and sometimes this did result in wording changes. We would then read the statement again and then ask participants to vote again. So the statement was deemed to have consensus if there were no closed fists. And we did this for a number of examples for health data uses that participants felt were within, not within, or could be within social license as long as there were appropriate safeguards in place. And we ended up coming up with 3 examples that everyone felt were within social license and 2 that were outside of social license. And now I'll pass it off to Annette.
Right. Thank you, Julia. I'm going to talk about some work that colleagues and I have done over the last 5 years now with the support of the Population Health Research Network and a growing group of collaborators. So 2 areas of work. The first, exploring community views about the appropriateness of using administrative health data with and by and in the private sector. And the second area of work, with the support of the PHRN, my university, Wollongong, Health Consumers New South Wales, Macquarie University, and funded by the Digital Health Cooperative Research Centre, focusing on community views, knowledge about, and attitudes towards the use of general practice data, predominantly for research purposes. So we've used a range of methods. First of all, we've used some focus groups. We used those in our general practice project, and we conducted them as a preamble to running a large community survey, which was then a preamble to running some community juries. Our focus groups we ran 4, they were pilots, so they weren't substantial and they only gave us an indication of what views might be. We ran them fully online with 2 mixed gender groups, one mixed gender group, 1 female only, 1 male only, and 1 young person's group. And in each of those focus groups, we gave them an unfolding scenario, which began with a woman going to her GP about her diabetes care, and then asked about the use of her data, who was likely to have what was likely to be in her record, who used her data, and then we progressively added an array of different scenarios and got the focus group's views about the acceptability of those uses and their reasons. That set of focus groups fed into a national survey, and we've run 2 surveys that are quite similar in design over the last few years. Both of them have used a convenience opt-in panel from a market research company. The first of them, focusing on the acceptability of using health administrative data by the private sector, was in May, June 2019, with a sample of just over 2,500. And the second survey in March of 2022 was about the use of general practice data for secondary purposes, and that had a sample of just over 2,600. We sought a sample that was comparable or nationally representative of Australia, and we weighted the findings according to the Australian census. In both cases, the survey could be completed in about 15 minutes. In the first case, we gave the participants a written summary of the key issues that we were interested in exploring. In our survey with general practice, about general practice use of data, we provided very short videos at 2 key points in the survey to give participants an understanding of what general practice data was and the ways in which it is being used for a range of settings and the sorts of controls and security arrangements and ethical governance that exists. Both of those pieces of survey work have led into 2 community juries which we've run. The first of them, which was by a whisker before COVID happened, was a jury that asked under what circumstances is it permissible for governments to share health data with private industry for research and development. And the second, in July and August of 2023, for which the charge was, under what circumstances, if any, should we share general practice data for research purposes? So a little about the community jury method that we've used. Community juries or citizens' juries bring together a diverse group of the broader population and asks them to acquire an understanding of the topic under consideration and to then deliberate about that topic and to make recommendations which can be used by policymakers. Typically, the kinds of issues that one will address are not straightforward ones. They're ones where understanding what is at stake in terms of the context, the background, the knowledge and skills are something that may need to be acquired to some degree for people to really have a full understanding of what the issues are. So in our community juries, and we did both of these in a similar way, we have recruited about 20 people per jury, and we bring them together for about 2.5 days in person. And in this case, for each of those charges, we run 2 juries. The first focused around private sector use of data in Sydney and Wollongong, and the second focused on use of general practice data in Melbourne and Sydney. In each case, the jurors receive about a day of information provision, where they have an opportunity to listen to experts who talk about the topic under consideration, to ask questions, to work in small groups, to form preliminary views, to feed those views back to the key witness presentations, to prepare them for their deliberative exercise, which then occurs over about a day and a half. Our key witness presentations, for example, for the general practice juries, gave people information about the nature of general practice in Australia, ways in which general practice data are collected. For example, the jurors had a copy of a general practice record that they could look at, the way and information about how those data are collected and then forwarded on to be collected up into a central repository. Information about the kinds of uses that general practice data are being put to, and then a substantial section on both the legal and the ethical situation and the kinds of controls that are on the use of general practice data. During the deliberation in both cases, our jurors have done both small group work and larger group work. They've often been invited in smaller groups to focus on 1 or 2 aspects of the larger charge and to bring their recommendations back to the larger group. At the end, or probably beginning in the last sort of half to 3/4 of a day, the jurors will start voting on the recommendations that have arisen from the deliberative exercises. And we have used a traffic light approach of red for no, I don't agree with this, orange, I'm not quite sure, and green, yes, I do. And we will invite jurors to vote and then ask for views from each side about, well, why did you say yes? And often ask people, what would it take for you to move towards consensus? So, as I said at the beginning, the focus is an opportunity for people to become informed, to deliberate together, and where possible, but not necessarily, to arrive at a consensus view. The people around the table are as diverse as we can make them. So we screen for diversity. In these juries, we've recruited through a market research company, we have asked that market research company to provide us with jurors who are broadly representative in terms of gender, age, employment status, occupation, income level, indigeneity, and language spoken at home. And I think that's the end of my section. So I'm now going to talk about the overall findings from these two approaches that Julia and I have described. So we've decided to put this together with a first section that I'm going to take you through on areas where we felt the findings across the two approaches that we've used in the work in Canada and our work here in Australia have some level of general agreement. And then we're each going to talk about a couple of areas where we found that there were differences between the findings that we've had. So I'm going to do the general agreement, and then we'll split up the different findings between us. So first of all, the general agreement area. Both of the work that we've done in both cases have suggested very similar findings with respect to community views about the need for benefits to arise to the population who contribute the health data. In both cases, because we're talking about health, there's been an emphasis on there needing to be benefits for the health and the well-being of the population. And part of the reason for this is to ensure that we're not wasting the data that are collected about people, and also to make the best use and to make more use of information that people are having collected about them. So for Canada, it was clear in their work that it is within social license for health data to be used to improve healthcare decisions, to understand the healthcare system, and to understand the drivers of disease and well-being. In Australia, similarly, our findings have shown that there's strong support for using health data for secondary purposes, provided there are public benefits and, in a more focused way, improvements to health outcomes. The Canadian work has been very clear also that it's not within health license, with social health license, within social license for health data to be used for a purpose that doesn't have patient, public, or societal benefits. And in each case, we've got a couple of quotations that are drawn from the work that's been done in Canada and Australia to give you a bit of a feel for how our participants have talked about these areas. And you'll see with respect to benefits that these are very similar. In Australia, talking about preventing an outbreak of COVID, finding cures for diseases, benefiting the whole population. In Canada, supporting team-based care, better diagnosis and treatment, avoiding harm, supporting optimised health system resource management, discovering new treatments. These quotations could almost be interchangeable. So the second area where we found similarities were with respect to equity and fairness. In the Canadian work, there's been a strong emphasis on Indigenous data sovereignty and the right for Indigenous self-determination, and to ensure that Indigenous self-determination is acknowledged and respected. Also, that health data are not being used in ways that create stigma or discriminated against groups, and that systemically marginalised populations have control over how their data are used, shared, or reused. In Australia, we found very similar things. A focus on needing to ensure that vulnerable communities are consulted and that they are not harmed and they are protected. And with respect to general practice data sets, also in one of our juries, a recommendation that the research that is done needs to actually be representative of the population that is being researched. And again, some quotes. The Australian Sydney jury on GP data usage were quite concerned that they thought they weren't representative of the broader population. And here's a quote saying, well, we actually have made a recommendation about consulting more vulnerable populations because we don't think that we can make a decision for people. We're not able to live in their shoes. The Canadian views a little more generalised. The problem of groups that have suffered for discrimination are not going to be solved by making it more difficult to use their data. Their well-being could even be harmed. So we have to be sure that those groups are represented and that they have particular protections in place. So our third area of commonality is governance and oversight. Both sets of work have had strong recommendations for independent governance bodies. Governance bodies that are broadly representative of the stakeholders, but also of the communities whose data are being used, and that there is transparency about the work of the governance body and how that work is done. In the Australian work, we've found that people are somewhat divided between thinking that an ethics committee might constitute that independent governance body, but in some cases also saying that it needs to go beyond that to have a broader group whose specific focus is making decisions about the use of health data for secondary purposes. In Canada, the findings suggested that the organisations that held health data needed to be seen as trustworthy by the organisations that contribute to them and also by the general community, and that also that we had accountable governance bodies and, as with Australia, external third-party oversight, and their suggestion was an Information and Privacy Commissioner. Same kind of focus also on the need for transparency in the use of data and the holding of that data and making the information available. So again, some quotations from Canada. Accountable governance bodies are needed, and that needs to include patients and publics. They will need to be able to levy severe penalties for those who misuse data or violate laws or regulations that relate to health data, because people have to trust that data are being collected properly and secured and used appropriately. And it can't be just the industry, the university or the government, but an independent body. Similarly, in Australia, lots of different stakeholders with varying interests that they represent. And the Sydney jury said there doesn't seem to be a way of looking at all of these things together where everyone has their say, which was why they were promoting an independent governance body. Next area of commonality was privacy and security. As a default practice in both the Canadian and the Australian work, removal of identifying information about individuals, removal of names, addresses, and dates of birth, public disclosure for misuse of data, penalties for data breaches, which you could also see in that last quotation from Canada, and very well-defined and clearly executed data security arrangements, which were also done regularly. Canadian, similarly, accountabilities for everyone who use it, security, particularly cybersecurity and other safeguards in place, and auditing, consequences for non-compliance. And in the Canadian case, a right to be forgotten. The Australian quote that we have here, similarly to that Canadian one from earlier on, focuses on the need for penalties for mistrust or misuse or selling information, and the need for those fines to be quite substantial, or for people to be jailed. In Canada, as within Australia, I think our jurors recognised from our jury work in Australia, in Canada, the participants recognised that people actually often were not aware of how their data was being used or being misused, and that we need to ensure that data are collected and held securely. And finally, again, a great deal of similarity around data transparency and data literacy. In both pieces of work, the need for transparent and plain language about what information is being collected, about whom, who has access to it, where it is being held, and how it is being used, and for what purposes. The results of work need to be made publicly available, and transparency, therefore, will follow from that about the research that's conducted both in the private sector, which was the Australian work, and in the general practice sector. In Canada, an opportunity for people to get answers to questions about how their data are being used, and for really good education materials to increase data literacy. And also in Australia, the same thing, available in formats that are tailored to meet the needs of particular audiences. So in Canada, participants said it's important that the purpose of data collection and storage is clear, well communicated, and known to participants if they request it. The language needs to be language that everyone understands. And in Australia, very similar. We wanted to prioritise that information should be accessible, trying to reach out to as many people as possible so everyone is aware of what they're getting into with this data. And I'm going to hand back.
Thank you, Annette and Julia. Fascinating stuff. Now, we've got a couple of Mentimeter questions, and then I think we'll let you have a quick break to grab a cup of tea or a toilet break. So let's get going with the first of the questions. So how do these results that you've just heard from Julia and Annette compare to your understanding of community attitudes towards the use of data for research? First of all, can you just list any similarities? Okay, great. Let's have a think about differences. So how do these results compare to your understanding of community attitudes towards the use of data research? And what are the differences between what you've experienced or your thoughts and what Julia and Annette have just presented? Like lots of similarities and no differences. Here we go. Okay. Thank you for all those really interesting responses. I think we should take a little break now. And so let's come back at the top of the hour. So 10 o'clock in Western Australia, midday on the East Coast. And we'll see you soon. Okay, we've got everybody back. Fantastic. Um, we had a question about the right to be forgotten in the Q&A, and I thought we might just get Julia to respond to that before we move on to the next section.
Absolutely. Thanks for that question. So this comment was really around when we were discussing privacy and consent. And the idea was that people can access information. Well, the suggestion was that people would be able to access information that is stored about their consent for health data, and then they could also be able to modify or withdraw their consent. So say if you provide your data for a particular study, but then you also give consent for that data to be used for other secondary use, so other studies just kind of put into a large bank of data, but then you decide one day that you don't want to have your data used for any other study or purpose. Is there a mechanism in place for you to say at that point, I don't want you to use my data anymore? I also saw a comment come up in the Mentimeter about similar or different findings about how this right to be forgotten had come up in discussions with you, and you didn't have the words. So hopefully that's something similar to what you had discussed. But if there are other or different ways to interpret that, I'd love to hear it. Feel free to put that in the chat as well.
Thanks, Julia. Okay, let's move on to our next section. I'll hand over to you, Julia and Annette.
So I'll start us off here. As Annette mentioned, we're now going to share some findings that were a little bit different between the two groups. Now, they weren't necessarily opposing views. I think in general, our findings were relatively aligned, but we did notice some obvious differences in terms of the level of support for different uses and users of health data. So the first category we'll focus on is personal control and consent. So in the discussions around control and consent, really this focused on two main areas. So the first being control over and access to one's own health data in a timely or even a real-time way. So just a little bit of context for that, as I assume the majority of people attending this are based in Australia, but in Canada, access to personal health information is quite inconsistent across provinces. So as an example, here in Newfoundland and Labrador, they've just rolled out a personal health record pilot program to a small portion of the population. So not everyone has immediate or almost real-time access to their health data, in this province at least. In other provinces they do, but it's not consistent. So that was kind of a big portion of the discussion when we talked about personal control and consent. And the second piece specifically around consent, in general, I would say opt-in consent was favored over opt-out, as there were particular concerns around privacy and security breaches, misuse of data, some mistrust. And that probably had to do with some where we were in time, post-pandemic, and we can talk about that a little bit later when we talk about local context. But I'll also say that on the other end of the spectrum, there were some people, and in our group, it was the minority of people, but some people did feel that if we had too many safeguards in place, this would prevent the benefits from being obtained from data. So in that sense, opt-out is the way to go. So here are a number of quotes from our participants. So you see a couple of quotes there around direct involvement with one's own health data. So that first quote there, the full quote is, "People deserve to have the slogan, 'Nothing about us without us,' applied to uses of their health data." And again, in these quotes, you will see kind of two ends of the spectrum here. So you'll see points about no sharing without consent, and also a point about how some people in certain situations, particularly in a healthcare setting, may be vulnerable and feel like they can't say no to sharing their data, even if they were given the option for consent. So there's that vulnerability piece. The two quotes on the bottom right-hand side of the slide reflect the other end of the spectrum. So essentially what these people are saying is, as long as there are certain safeguards in place, data should be relatively available, and there is an issue with too much protection and opt-in as opposed to opt-out.
So as Julia has said, the findings that we have collected up in Australia are slightly different, but I'm going to preface that by saying that it's particularly coming from our community juries, which does require a bit of explanation. Both of the surveys that we've run has had, by a relatively small margin, support for opt-in consent. When we've gone to the juries, however, and we have an opportunity to talk through that full range of matters around the uses of secondary uses of health data, the differences in the amount of support that one gets from the community, depending on whether you use opt-in or opt-out consent or even a waiver of consent, and an opportunity for jurors to reflect together on what consent represents, i.e. personal control over information about oneself, and how the greatest benefits can be gained from making use of health data, which is when you have full data sets. When all of those things are in play, in our community juries, both sets of work and both juries in both sets of work move at least to an opt-out consent model, or they moved to a waiver of consent model. In the general practice jury, there was strong support for opt-out consent, but also for choice for patients of general practices as to which of their data could be shared and which they might want not to be shared at all. And that there would be relevant and appropriate community involvement to ensure that the consent mechanisms that were in place were actually being realised. Our private sector juries predominantly favoured a complete waiver of consent model, and if not that, then definitely an opt-out consent model. Oops, can you move on? Because my little button has frozen. So this is a really nice example from one of our juries. And I think it both picks up the notion that you get the best data, so you get the best population benefit, but also that if people don't have an option of opting out, then the risk is that people will not go to the doctor, and that'll have a negative impact on people's health. So at least here, people have the opportunity to opt out. So it's very much weighing up the benefits and the risks or the potential for lack of benefit that attaches to these various consent models.
Thanks, Annette. So now we'll move on to our last category within our findings, and that is of commercial organizations. So in general, at least what we see here is that there tends to be more mistrust or distrust in the private sector or commercial organizations compared to the public sector. Now, that's not to say that there's blind trust in the public sector and governments either, but generally we do see more mistrust when we're talking about private sector access to health data. So throughout our process, people highlighted the importance of data not being sold or used for marketing purposes, and that commercial organizations, and that was whether they were pharmaceutical companies, insurance companies, or other private sector companies, should have additional safeguards, conditions, and protections in place when using health data. And you can see there on the bottom of the slide, that was one of the examples that all of our participants came to consensus on as being not within social license for someone or some organization to sell someone else's identified health data. As an example about private sector use, one of HDRN Canada's member organizations is ICES. They're based in Ontario, and they hold most of the administrative health data for the province of Ontario that researchers can access to conduct their research. ICES also offer data analytics services for private sector researchers, but they do have additional safeguards in place, so quite in line with what our participants had recommended. So these additional safeguards aren't necessary for the majority of researchers, who ICES works with, who are primarily from academic institutions. So as an example, for private sector researchers, there's no access to individual level data. So they essentially work with an ICES analyst who generates the reports that are required for them. In addition, ICES scientists are prohibited from receiving industry funding for projects using ICES data, and the majority of ICES's work is still within the public sector. So I think that's a practical kind of real life example of what we heard from our participants regarding the private sector. And again, some quotes from participants, which you can see, we did see kind of two ends of the spectrum here. So on one end, I'd say a lot of people felt that commercial organizations care about the bottom line, which is essentially profit and creating wealth for their shareholders. And at the very end of the spectrum, there was one individual who said, no data should be provided to commercial organizations, full stop. Then you see somewhere along the middle, so people are thinking, okay, it's fine to share as long as there are proper controls. So examples were given: insurance companies, medical device manufacturers, drug companies, legal firms. And then those last two quotes at the bottom there are at the other end of the spectrum. So people feeling that data should be made available to the private sector for public good and innovation. So data really needs to be liberated, even when it comes to de-identified information, which was surprising. So really, really kind of vast array of opinions, and a diverse array of opinions based on or for commercial organizations.
I think partly because we've run a national survey and two juries that specifically focused on what role, if any, or what access, if any, can the private sector in Australia have to health data. Our findings are perhaps a little different because people aren't always doing a comparative exercise. And I'm going to talk here particularly about the findings from the juries because they're the richest. Both of our juries that were asked the question about whether it's permissible for private organisations to access health data for research purposes said that that was acceptable for research and development. And they had a range of, however, they had a range of conditions on that general view, 14 for one jury and 19 for the other. First of all, they wanted controls on who could access. And there was a very strong view that insurance companies should not be able to access health data under any circumstances, whereas pharmaceutical companies, medical device developers were acceptable. In some cases, some jurors suggested that the data was best shared if it were in aggregate form, but there were also recommendations that that data be able to be accessed as individual unit records, provided all of the identifying information, names, addresses, and dates of birth had been removed. Really, really strong commitment to oversight by an independent body. And again, a very strong purpose to suggest that it would be acceptable provided the uses of the data were in the public interest, and it would be the independent bodies that would assess whether it was acceptable to release the data, and by evaluating whether the purposes that the company applying was suggesting actually were going to be in the public interest. Very strong protections. In both cases, in those juries, a recommendation that the private sector needed to pay for access to data. And in one of the juries particularly, recommendations that what they pay needs to go back to improve the health system. Same kinds of recommendations as in all of the work we've talked about to date about the need to make sure that the public is well informed about private sector use, and both who's holding the data, what they're doing with it, and what the outcomes are. And as I said before, for those juries, either a waiver of consent or an opt-out consent model. The strong penalties was a really interesting area, and there wasn't consensus about this. About not so much, but I think everyone thought that there should be strong penalties, and there were recommendations that there should be penalties and strong financial penalties for misusing data. But the blaming, the publicising and blaming and shaming was more important. So from this quote, you can see a lot of big companies are likely to be adversely affected, not by the fine, but by the impact on their reputation. So having transparency about both use and misuse was really important to the jurors.
And I think that brings us to some reflections and emerging issues before we get into the question and answer period. So I think in general, we can all agree that public perspectives on data collection, use, and sharing are complex. In general, we see broad public support for the collection, use, and sharing of health data, but requirements and safeguards do matter, and that's this idea of conditional support. There are some uses of health data that appear to have more support than others in certain circumstances. So public over private, profit is not looked upon favorably by the public, as well as data use that causes discrimination or bias, particularly for systemically marginalized populations. And in some cases, at least what we saw was that people will oppose a use or user of health data no matter what conditions are in place, or what conditions are met or safeguards are in place. So, when in looking at research that uses secondary data or links data, it is really important to consider who collected the data, for what purposes, and the implications for sharing and using the data for the data owners, who are the public. And this is really imperative for public trust, which is how we'll be able to get the most benefits out of the large amount of data that exists out there. So to close things off, we reflected on the work we did in both countries and wanted to provide some of these reflections on perhaps, again, we saw similarities and differences in perspectives. And Annette, I encourage you to chime in on any of these points. So of course, we took relatively different methods to understand public perspectives on health data use. So in Canada, we used generative dialogue and inclusive design approach to highlight minority views. In Australia, as Annette mentioned, there was a combination of focus groups, community juries, national surveys. In terms of the populations, the obvious being that we're having two different populations in Canada versus Australia. I would say the groups in general were quite diverse. For the juries and the dialogues, they were as diverse as possible, even for a small sample. Of course, in Australia with the survey, that was a much larger representative sample. I will note, and I mentioned this before, but I think a very important limitation of our work that needs to be acknowledged is that we engaged with experienced patient and public advisors. So these are people who already had at least some idea about health data. So in that case, they were more likely to know about both the benefits and the risks of health data use. So in that case, there were probably kind of uses of health data that our group felt were within social license that maybe other people would feel like were outside of social license. So we've done some kind of some discussion after this work to talk about how we would replicate this by engaging with people who don't know anything about health data. And I don't know if you want to add anything about the population or even the methods.
I think we had the opportunity to ask our jurors in both sets of work to complete the survey that our national sample had filled out earlier. And what we saw in both cases was a move to greater levels of support for data sharing, to more support for opt-out or waiver of consent models, to more support for private sector usage of health data. And so I think what it suggests is that our surveys give us a top of mind perspective, what are relatively new to thinking about this or haven't and are not taking a lot of time to think about it when completing a survey group of people will consider, as opposed to the juries where they really do develop a quite in-depth understanding of that particular topic. The other point that I wanted to make is about local context. Our juries about the use of general practice data, although they came to very similar recommendations, were quite different in the tone of the conversations. The Sydney jury, things were very matter of fact, and there was a great deal of support. Where there were concerns, by and large, they found ways to get around those or to manage them. The Melbourne jury, the concerns that they had about data security, about government access to data, about what could be done with your information, and about the potential for misuse were far more heightened. And our jurors reminded us that Melbourne was the most locked down city in the world during COVID, and that to some degree, the topic that we were addressing with them had tapped into that set of concerns and anxieties about what governments do during major health events. So I think even that gives you a little bit of an understanding about how things can vary so much depending on the context.
Thanks, Annette. And related to that, I was kind of thinking along the same lines. So the work that we completed in Canada, it spanned 2021 to 2022, so arguably kind of middle of the pandemic. So here, I think people were beginning to understand the importance of having accurate data available to understand population trends. So for COVID, it would be things like understanding disease, diagnoses, vaccinations, those sorts of things. But coming out around that same time as well was the development of the Pan-Canadian Health Data Strategy. And this was spurred really by the realization that there were significant gaps in our health data ecosystem. And one other thing I will mention, and this is something that we noticed in conducting our dialogue sessions, because as I mentioned, we conducted separate sessions in English and French. And in the French sessions, all of the individuals were residing in Quebec. And in 2022, there were two bills that came into effect. One that was an Act on Health and Social Service Information, so that really established new legislative frameworks for health data sharing or data sharing and use. And another was aimed at making the healthcare system more efficient. But these bills came into effect around the time that we were doing our dialogues. And we did notice, and again, this was a crude kind of analysis, just a notice after the fact, that the people in the French-speaking group, so those who resided in Quebec, seemed to err on the side of caution and were a little bit more concerned with privacy breaches, just in general, a little bit less supportive of kind of liberating data for all. And, there's probably many reasons why that would be. And we didn't go into these dialogues trying to see differences between English and French groups at all, but that is something we noticed. And so there was a possibility that all of this chatter and the talk about these new bills and new legislative requirements that were coming out in the province of Quebec could have impacted that. And finally, of course, the way that you ask a question in research is going to is going to impact what you find, right? So that's that question there on the slide. But as we have mentioned throughout this session, in Canada, we were focusing kind of about this general level of support, and Annette and her team had these more specific questions on the use of GP data as well as private sector data. So of course, we're going to see differences, and particularly in the level of information that we're going to get. So Annette, I would say that you and your team got a lot more kind of in-depth information about private sector perspectives as opposed to us. That was one component of it, but it wasn't a huge part of it.
Okay, so that's the end of our presentations, and we've got a couple more Mentimeter questions, but these are the last of the Mentimeter questions, and then we're going to move on to questions and answers. So feel free, once you've answered your Mentimeter questions, to pop your questions in the Q&A box, and Julia and Annette will be more than delighted to answer as many as they can. So the first question, and I should frame this a little bit, in Australia, particularly for the PHRN, our funder is very keen on the provision of research infrastructure to support commercial uses and translation of research. So this is why we've been particularly interested in this question. So just to let you know why we're asking you this question. So what do you see as the biggest barriers for Australia in sharing health data with commercial organisations? Okay, looks like responses are slowing down. No, still a few more. Let them come in. Okay, I think we might be there. Okay, let's move on to the next question. Okay, so in this one, we're wanting to think about how do we keep our finger on the pulse of changes in community attitudes to these sorts of things, and what kinds of methods could we use to do this, based on the assumption that community attitudes are not static. They're going to change over time and in response to either major events like a pandemic, for example, or just sort of shift over time. Okay, so it's looking like we've got lots of different ideas about this. This is excellent. Give you a little bit more time, and then I think we can vote on our favorite methods. Five more seconds for anybody who's got a last minute thought. Okay, all right, let's see if we can vote on which methods we think would be the most useful. It's a very long list, I understand, for people to scroll through. Okay, it looks like people are having trouble voting. I'm not sure if we can fix that. So with our technical team in the background trying to work out whether we can fix that. Okay, I think we could try, well, if people could try to refresh their page, it might work. But I'm not sure about that. Yeah. Okay, I think we might, it was a good idea. I think we might have had a technical fail on this one. All right. So I think we can move on to Q&A. Sorry about that. So we've got plenty of time, and Annette and Julia have lots of experience that they're very willing to share with you. So let's move on to some questions. Now we already have a couple of questions in the Q&A, so we'll start with those, but everybody should feel very free to add more questions. So let's start with the first question, which I think is about citizens' jury. So I'm going to send it to you, Annette. Are there systemic consumer advocates, expert witnesses, to introduce the so what from a consumer perspective as distinct from a health professional and a health system perspective?
And the short answer is yes. All of the juries that I've run have consumer advocates in different contexts with other kinds of juries outside of the ones I've talked about today. We have people with lived experience as well.
Okay, excellent. Next question is, And probably either one of you both may have something to say about this. Was there any views around accessing the data to create intellectual property for commercial benefit, e.g. creation of proprietary techniques or algorithms?
There
Julia?
was, I'll just quickly answer. I can't think of aspects of the conversations that were held in our juries, because it would have been there if it were, that's particularly focused on intellectual property as it relates to AI and algorithms. There was a general acceptance. Oh, that's not quite true. There was some discussion about intellectual property more generally, and an acceptance to some degree that that would be reasonable. But bearing in mind that we weren't really focused on that. I'd have to say I don't think it was clear.
Yeah, I would agree with that on our end as well. Again, we didn't have that much time to focus specifically on commercial uses as well. So from what I recall, that specifically wasn't addressed or touched on.
Okay. Next question. How do you, and this is definitely for Annette, how do you see these results informing the current NHMRC HREC guidelines for the use of health data in research?
So the second piece of work that we've been doing specifically about research use of general practice data is going to have a component of it in the next 12 months that will talk to legislators, policymakers, HREC chairs about the way in which our findings might inform their own work and might contribute to revisions of the national statement. So we're not at that point yet, but we are intending to pursue that.
And maybe just to extend that to you, Julia, do you see any of the work that you do having an impact on things like the trination? Is it a trination statement that you have?
Yeah, the TCPS. Yeah, I think so. It's something that we're exploring now, and I think there was a lot of discussion raised during our sessions around ethics and things like that. So I think there would definitely be some impact on what we found and how we can kind of relate to that for sure.
Next question. Were HRECs considered to be independent review or governance bodies from a consumer perspective?
I think the answer is probably both at times, and sometime, yeah. So where there were recommendations in the juries that there be an independent governance body in addition to the HREC, it was also what they also wanted was that the key stakeholders have a place at the table. So a governance body doesn't, and from that, on that view, wasn't necessarily completely independent and with no engagement, say, by the private sector. But it needed so there was an interest both in ensuring that all parties were represented. I think where those recommendations were made about a separate governance body, they understood that there was always going to be HREC review. And some recommendations in some of the juries thought that the HREC review was adequate. Some wanted additional layers as well.
Yeah,
and do you want to add from a Canadian perspective?
Yeah, I'm just recalling when we discussed about kind of this need for external third-party oversight. There were a couple of specific examples given, and one was data stewards and the other was an information and privacy commissioner. But to Annette's point, there was also recommendations that this external third-party oversight would be a collaboration formed by academia, government, industry, other relevant stakeholders, and including patients and the public as well. And I think generally, like, people felt that well, HREB here, the Health Research Ethics Board, would be kind of an aside to that. That would always have to go through ethics, but then in addition, we would have this external third body oversight that would be comprised of a number of different stakeholders.
So that's very similar.
Yeah.
Yeah. And just a question from me to extend on that. In any of these studies, did the community raise the issue of administrative burden, resourcing, cost of independent oversight?
Yes. So in our private sector work, I think one of the possibilities was that the private sector could fund the independent oversight body. If not that, then the government is responsible for ensuring that there is adequate independent oversight. And the rationale is along the lines of if we're going to maintain trust both in government and in the parties who access data, then we need this kind of a process in place.
Yes, and on our end, when you said burden Felicity, I kind of got two things in my head. Not specifically related to third-party oversight or governance, but there was some discussion around the fact that any sort of control or safeguards that are in place around health data can't be so burdensome that they prevent benefits from being obtained. And there was also another discussion around the actual point of data collection, what we're talking about at the healthcare or the health delivery level, and making sure that that's not an additional burden on healthcare providers if they're the ones that are collecting it. Make sure that's not burdensome in addition to everything else that they're doing. So those were kind of two related somewhat to your question.
Now I'm seeing that we might, yes, we do. We think we've solved our technical problems with our voting exercise. So we might give that a go. I see some people are already in there, but yes. So voting is open for what's your favorite method for monitoring changes in community attitudes? And you can select more than one, I think. So you can have your top 3 or your top 5. Just a few seconds left. Excellent. So it looks like we've got 3 really clear winners from this. And I'm wondering whether people might pop in the Q&A if they've had any experience of specific methods for going about these things. So the 3 are: increased communication with communities, involve consumers in internal decision making, and integrating community members into data governance processes. I think those last 2 are probably a little bit similar. So if you've had any experience in doing any of those things, keen to hear from you in the Q&A. But in the meantime, Julia and Annette, have you got any thoughts on those 3 options?
So I can speak briefly to a very large data set of general practice data, which is run by the Department of Health in New South Wales, which is called Lumos. And Lumos is run in conjunction with the population health networks in Australia. And that data set, which is evolving and growing all the time, has a data governance committee with 2 consumer representatives on it. And it also has a separate consumer panel. So there's a good process there for engaging consumers in decisions about, for example, which applications for access to data will be approved and which ones won't. There's currently a process of enhancing the quality of information provision that goes out to the general community about the use of the Lumos data set. So I think we're seeing some good things in that sphere.
And I'll just add on to that. I thought it was neat that the 3 most kind of popular choices are really, we're talking about patient and public engagement and involvement. You know, some of the others there, we're all engaging with the public in some way, but it's, I would say, at the lower end of the spectrum in terms of that 2-way communication. But, you know, when we're saying integrating community members into data governance processes or involving consumers in informed decision making, if we're talking about patient oriented or kind of well, in the case of patient-oriented research, that kind of, that highest end of the spectrum there is empowering and giving patients and the public the actual power to make decision, as opposed to just that one way, oh yeah, we're involving you by giving you a survey or letting you give us your feedback, but actually giving them that power to make decisions. So it's interesting to see that the most popular ones have that aspect of that 2-way kind of empowerment in engagement.
Yes, so one of the questions we've had come in is sort of along those lines. I'm mindful that the same individuals are often asked to be on boards and internal processes. Could you share any experiences of inviting community members who may not previously have been involved in research or advisory committees?
Oh yes, this is like, at least, sorry, Annette, I'll just very briefly, this is like the age-old question for us in patient and public engagement, at least here in Canada, because you tend to see, when you're going out trying to engage with the public, you see the same people that you are engaging with. And here we've what would I say? You're almost, at some point, people are so engaged as patient partners and as members of patient advisory boards or public advisory boards that they're actually becoming professional patient partners. And in that sense, they kind of lose that public aspect. But there are a lot of significant issues and barriers to reaching out to these other individuals who do not have the capacity to participate in this type of work, particularly those who are in systemically marginalized communities and other vulnerable situations. That this is the last thing that they're going to be wanting to be doing, is engaging with us on telling us about how they feel about health data, right? So that is the challenge that we always run into. And I don't think I have a solution, but engaging with local community groups who actually have direct contact with individuals in certain areas has worked in the past. So kind of building those relationships with community groups, not-for-profit organizations, those sorts of things have worked for us in the past. And that's where I think I interrupted you.
I was going to say exactly the same thing. It is a challenge, I think. Even if one begins with community members who are less familiar with the topic area, they become familiar with it. Now, whether that's a disadvantage or not, my observation of community members on boards, on ethics committees, is that they don't lose their roots. They remain connected. They remain very clearly aware that they're in a particular position, and that brings with it some obligations with respect to understanding and reflecting more general community views. So I do take the point. I think one of the questions is about the burden. And it does require some ingenuity, I think, to find people who are outside of a smaller group and to ensure that we're getting broad representation. And ironically, the more local you go, the easier it is, I think, to find. The more precise the area that you're working on, the more. And so, for example, if it is alcohol and other drugs and you're working with particular community organisations, it's often rather easier to get a representative group of consumers together than it is if your question is health data use in Australia, where your potential population is gigantic.
Yeah. Now, I'm noticing in some of the suggestions people are putting in the Q&A things like paying consumer reps and qualifying them. Wonder if you've got any comments about those sorts of ideas to encourage people to put their hand up to be involved in what's often quite time consuming, actually.
I think that the sentiment has shifted in the last 5 years quite strongly towards appropriate payment for involvement by community members, not only for their time, but recognising that they have specific expertise that they can bring to bear, and that expertise needs to be valued. So I think we've had a real shift there. And I also, just reflecting on the ethics committees that I chair, the mood has shifted very quickly there from it's likely to be coercive if we're paying consumer members on panels to no, we really must recognise people's contribution, and so people do need to be remunerated for their involvement. So I think that is becoming less of an issue. The amount of remuneration is obviously always going to be a challenge, because many of these settings themselves are ones in which there's not a great deal of resource to go around to make sure that decisions are broadly representative of the community. So I think that's a challenge.
Yeah, and I think that the same thing here in Canada. I'm engaged quite deeply with the strategy for patient-oriented research, and they have honorarium guidelines, or each of the units and each of the provinces and territories have specific honorarium guidelines for patient partners or members of the public. And we actually just recently put together a summary of all the different guidelines, because they are, and it's funny because they do vary a little bit province to province, but they're very specific in terms of the type of honorarium, whether it's, a payment, is it something else? Because there's non-monetary ways to appreciate members of the public or consumers, right? And then of course, when you're talking about engaging with Indigenous populations, there's a whole other kind of set of recommendations for that. But there are challenges when engaging with the public and then providing honorarium or other types of payment. A lot of times there can be impacts on taxes for people who are not working, at least here in Canada. And we've also run into kind of more bureaucratic or kind of university level issues in terms of human resources and just being able to pay our members of the public in an easy way, just because of rules and policies within the university. So there are definitely challenges, but it's recognized that it's a very important part of patient and public engagement.
Okay. Well, our time is nearly up, and so I don't know whether Annette and Julia, you have any last comments that you'd like to make before we wrap up?
I think only to say that it has been a wonderful exercise to be able to work with Julia, particularly identifying there are so many areas where we do think similarly, with respect to our community being involved in making decisions about the use of their health data. And that's I think that's a very reassuring thought for the future.
Yeah, it's been really, really interesting, and we're looking forward to doing this again in a couple of weeks for a Canadian audience, and it's going to be very interesting to see if there are any similarities or differences in the people who attend that session as well. So I'm looking forward to that.
Okay, so first of all, thank you so much to Julia and Annette. It's been a great workshop, and it's been a delight working with the two of you to bring this all together. And as Julia mentioned, this is part of a Australian-Canadian collaboration. So we will be repeating this workshop, but in a Canadian appropriate time in a couple of weeks for a Canadian audience. And then once that's been done, we're going to summarize both the presentations and the feedback that we've got, and we'll be feeding that back to all of the participants of both of the workshops. So you'll get to see what the Canadians thought as well as what the Australians thought. So we think that'll be a really useful exercise for everybody. You'll notice that in the Mentimeter, we've got an evaluation survey up there now. So we encourage you to fill that out before we end the webinar today. And also I need to thank the team both in Canada and Australia in the background that's been helping us with the technical support and graphic design and all sorts of things in the background. It's been really useful. So thanks to the team. The communications officers as well have been wonderful as well. So it's really a wonderful exercise to work with the Canadians on these sorts of things. So I think that's all. Keep an eye out. We will be in touch with summaries of the workshops in due course. Right. And I think we will end it there. Thank you very much to everybody. And thank you to everybody who came along and played with the Mentimeter with us.
Thanks,
That's been
everyone.
really useful.
Thank you.
Thank you.